Okay, Unit 8 is about oxygenation, and we're going to do a brief overview of anatomy and physiology. One of the reasons that you need to understand anatomy and physiology of the respiratory system in part is to do an accurate assessment, but also you need to be able to identify where problems might be occurring. When we have problems such as airway clearance, is it occurring in the trachea? Is it occurring in the bronchi or the bronchioles? Is it because the cilia have been damaged from smoking, or is it because there's a tumor blocking the airway or large amounts of secretions? If it's a problem with gas exchange, again, is it a problem that the alveoli are filled with fluid, or the alveoli have collapsed, or that air is being trapped in the alveoli? Or is it a problem of circulation, which is also going to impact gas exchange? So you want to be able to track the flow of air from the nose or mouth through all the way to the alveoli or alveolar sacs. And so the flow of air goes from the nose across the pharynx, and the pharynx is the back of the throat. You can have the nasopharynx and the oral pharynx. Then it goes past the larynx, and what isn't listed here is the epiglottis, which is above the larynx and is a piece of tissue that closes over the larynx when we swallow to prevent food and fluid from entering into the trachea. Once we're past the larynx, then we enter what we consider a sterile area. So anything above the larynx is non-sterile, and below the larynx is sterile. So we enter into the trachea, and the trachea runs center down behind the sternum, and about the level of intercostal space 2-ish, somewhere in there, it bifurcates and it branches off into the right and left main stem bronchi, which are then considered part of the lungs. And the bronchi continue to get smaller and smaller until we have the bronchioles. And lining the bronchi and the trachea are cilia, and cilia are cells, specialized cells that have hair-like projections that move, and they move mucus and debris upward into the trachea so that it can be coughed out or expectorated. Then it's into the alveolar sacs, which are the grape-like clusters at the end of the bronchioles and atria. And this is where gas exchange occurs. And when we breathe, we take deep enough breaths to fill those alveolar sacs with air, and oxygen diffuses across the single cell layer of the alveolar walls into the single cell layer of the capillary, or through the single cell layer of the capillary into the bloodstream. At the same time, carbon dioxide is going the other direction from the bloodstream across the capillary wall, across the alveolar wall, and into the alveolar sac, where it's then exhaled through the atria, the bronchioles, the bronchi, the trachea, the pharynx, and the nose or mouth. You know that the lungs, there are two lungs. The right lung has 3 lobes. The left lung has 2 lobes. The left lung is slightly smaller than the right lung. It has makes room for the heart and the structures associated with the heart. So there's the cardiac notch that you'll notice there's just kind of a little crescent shape out of the inner aspect of the left lobe, left lung. The pleural space is created by the pleura, the thin membrane, one or two thin membranes. One covers the lungs and the other adheres to the chest wall. And there's just a very minuscule space, fluid-filled space, that when the lungs expand, allows the lungs to glide over the chest wall rather than sticking and rubbing. But it's also a potential site for problems. If too much fluid builds up, infection can occur. If it's the integrity of the pleura is broken so that there's a hole, then that can cause problems with collapsed lung, pressure being placed on the lungs and decreasing the amount of airspace available for gas exchange. And they can just become dry and rub together and cause pain and discomfort. The diaphragm is the muscle that runs along below the lungs and kind of divides the abdominal cavity from the thoracic cavity. It is the muscle that does the main work of breathing. It contracts, pulling downward, causing the lungs to expand. The pressure inside the lungs then becomes lesser than the atmospheric pressure, and all things want to be equal, so air rushes in. And then when we exhale, the diaphragm relaxes, increasing the pressure in the lungs, and air is forced outward. The chest wall, you want to know where, if you're looking at the chest, you want to know where the lungs are, where each individual lobe is, where the bronchia, the right and left main stem bronchi are in relation to what you see on the chest wall, both anteriorly, posteriorly, and laterally. Things like knowing that if you don't listen laterally, especially on the right, you won't hear that right middle lobe. Posteriorly, we primarily are hearing the lower lobes. Anteriorly, we're primarily hearing the upper lobes, just because of how the lungs are situated in the chest cavity. So you use your landmarks like your intercostal spaces. The lungs typically end approximately the fifth intercostal space, especially during exhalation, and then they extend farther towards the ninth intercostal space during exhalation or inhalation. I don't know what I'm saying. So this is just a graphic to show you the things that we're talking about, where the lungs are. Notice that they extend above the clavicles, and so it never hurts to listen there. And you can see the sternal notch in the left, in that first picture on the left. You can see the sternal notch in the left lobe. The upper right picture shows the pleural space, and obviously it's magnified a lot so that you can see that space there. And then you've got your lungs, where they're located, and you can see that it extends just slightly below where we would listen to the point of maximal impulse, or the apical pulse. Now, the function of the lungs is to ventilate. Remember that ventilation and respiration aren't exactly the same. Ventilation simply refers to movement of air. Respiration refers to gas exchange. And just because we're moving air in and out of our lungs does not mean that we are respirating or having gas exchange. A lot of things can impair ventilation. A distended abdomen, structural dysfunctions of the skeletal system, such as scoliosis or pain, such as from a cracked rib or something, minimizes ventilation so that we're not moving as much air. Medications such as morphine or anything that depresses the respiratory center, these will all impair ventilation. Having fluid buildup impairs the movement of air. So anything that impairs ventilation has the potential to impair gas exchange as well. And as I've said before, ventilation, inspiration is an active process, requires contraction of the diaphragm, and in cases of difficulty breathing, it even involves the muscles between the ribs and possibly a change in posture. People will sit up more, lean forward to improve ventilation. Exhalation is a passive process. Perfusion is also needs to be considered when we're discussing the respiratory system. If the lungs are not adequately perfused, meaning they don't have adequate circulation, then obviously it doesn't matter how well we're ventilating, gas exchange is not going to occur and the patient will not be adequately oxygenated. So perfusion involves the cardiac or cardiovascular system and can be affected by heart failure, shock, meaning there's not enough blood circulating. We need adequate circulation in order to have adequate perfusion. There are many tests that can help to diagnose ventilation problems. The primary test that is going to help us measure perfusion and diffusion will be arterial blood gases, and we'll talk more about that in a little bit. Diffusion is an interdependent component of perfusion. If we don't have adequate perfusion, we're not going to have adequate diffusion. But this is the exchange of respiratory gases in the alveoli and the capillaries of the body tissue. The thickness of the membranes of both the alveoli and the capillaries are going to impact diffusion. So a patient with extensive atherosclerosis may have inadequate diffusion. Diffusion is a passive process based on the concentration of oxygen and carbon dioxide. So when we take a breath in, there's a higher concentration of oxygen in the alveoli than in the blood. And so, again, everything wants to try to be equal, so it's going to move across from alveoli to capillary, and then there's more carbon dioxide in the capillaries than in the alveoli, and so that moves the other way. One of the things that's required for adequate diffusion is hemoglobin. And hemoglobin is a component of red blood cells that is attracted to, or oxygen is attracted to. So we need to have adequate hemoglobin in order for diffusion to occur, because the hemoglobin is what's carrying the oxygen and carbon dioxide around through the body. The pulmonary circulation is interesting in that typically when vessels leave the heart, they contain the oxygenated blood. And all vessels leaving the heart are considered arteries. All vessels returning to the heart are considered veins. In the case of pulmonary circulation, unoxygenated blood leaves the heart through the artery, the pulmonary artery, and enters the lungs where it's oxygenated and returns to the heart through the pulmonary vein, oxygenated blood, which is then circulated through the body as it exits the heart through the aorta. So the pulmonary system is the only one where unoxygenated blood leaves the heart and oxygenated blood returns to the heart. Besides oxygenation, the respiratory system also plays a huge role in acid-base balance. The lungs adapt rapidly to acid-base imbalances and act quickly to return the pH to normal. That's the goal, is to maintain that pH between 7.35 and 7.45. Now, how does the respiratory system do this? It all comes back to carbon dioxide. Carbon dioxide has the potential to become a weak acid. So when carbon dioxide is mixed with water, we get carbonic acid. And by excreting or retaining carbon dioxide, the lungs can impact the pH. So if we increase ventilation, then if everything else is working well, including perfusion and diffusion, so we have adequate gas exchange, then an increase in ventilation will cause us to get rid of carbon dioxide. So if we think of carbon dioxide as an acid, we're getting rid of acid. And what is that going to do to the acid-base balance of the body? I'm going to let you think about that for a second. So we're getting rid of acid in the form of carbonic acid or carbon dioxide. And if we don't have as much acid, it's going to do what? It's going to cause an alkaline environment, so we have more of a base. So if the pH drops below 7.35, the respiratory system will adapt. So we will either take faster or deeper, or in sometimes both, breaths, and this is automatic. We don't have a control over it, and exhale more carbon dioxide, so that we raise the pH above 7.35. So anything below 7.35 is acidic. Anything above 7.45 is alkalinic, or alkalytic. I'm sorry, I said that wrong. On the reverse side of that, if we hypoventilate, meaning we slow the respiratory rate down, or we take shallow breaths, then we're going to retain carbon dioxide, which then will has the potential to